So I invite the next speaker, Dr. MANOJ CHADHA. He's a very senior consultant endocrinologist and my sir, my mentor from Hinduja Hospital, Mumbai. And he was a teacher of lots of an endocrinologist from western part of in India. He was past president of ESI. He was the past president of Indian Society of Bone and Mineral Disease. He is a member of an Asia Pacific Regional Committee of IOF, and he has more than 60 publications. He is going to speak on navigating hypopituitarism, practical-based discussion for physician. Over to you, sir.
Thank you, Pankaj, and thank you to the organizing committee for inviting me to this interesting session. Well, Cushing's, as I said, is the most difficult thing to diagnose and manage, and I think Nalini will agree to that because she's the master of Cushing's. Hypopituitarism, as I was asked to speak on, is probably not so common in practice. Not that it's not there, it's more often missed out. So the idea here is not to give you a detailed discussion on hypopituitarism, but just to sensitize you so that you all start thinking in your clinical practice. So we could go over the next 20 minutes or so, some common issues with the pituitary in relation to hypopituitarism. And 3 cases I have put up here, thanks to Pankaj, where we will see what we could have done. What we did was enough or something better. This young lady, I would say, by my definition of young and middle age, because I still am approaching middle age. So she was brought to the hospital with an altered sensorium, and the history was that she was not been too well the last few weeks, generally tired, not eating well. There's no significant past history in terms of diabetes or medical illness. But one thing was sure, was that she delivered about 14, 15 years ago last, and then after that, the menstrual history was not clear. I mean, the husband could not tell whether she really did get menses or not. So that was something that we kept in mind. The other 48-year-old male, again, very vague, non-specific things. So trying to stress here that you're not going to get clear-cut symptoms when the patients come to you. You have to look for signs in these people. Because fatigue, today I think out of 10 patients who come to the clinic, 7 will be complaining of fatigue, 8 will be complaining of hair loss, dry skin, so it really doesn't help you. But the duration, the medical treatment, if they've taken something in the past, may give you some idea. And in this patient, there was a history of head injury. Again, very non-specific, but there was something that we could catch on to. And blood pressure again was on the lower side, 100/60. The third lady that we're trying to discuss here was, I think, the diagnosis was pretty clear. Frequency of urine practically every hour through the day and night. Large urinary volume, drinking a lot of water. So the diagnosis was very much suggestive of a polyuria syndrome, and she was not diabetic, so this was suggestive of diabetes insipidus. 2 or 3 things that you must think of when a patient comes with this history of frequency of urine and polydipsia is this a slowly progressive disorder, or can they time it pretty accurately? This happened 2 years ago during this celebration or this occasion, or after an episode of illness. You know, when they are so specific, then that's suggestive of central diabetes insipidus. The other thing, when you ask them for their polydipsia, they'll say that they like to have cold water, not just water. So these are 2 or 3 things which you should keep in mind. And the not so rare, I mean, you do come across patients who have been told earlier on that drinking water is good for health. So what starts off as 3, 4, 5 liters then goes on to much more. And these patients generally have polyuria, but their sleep is not disturbed. So keep that in mind. So when we are talking in terms of hypopituitarism, deficiency of one or multiple hormones is what we are talking about. And if it's a total deficiency of all the pituitary hormones, then we call that as pan-hypopituitarism. And just one slide to tell you the anterior from the posterior pituitary, the common hormones that come from the anterior pituitary, growth hormone, gonadotropins, ACTs, TSH. Prolactin is not really from anterior pituitary, but it's secreted from there. And vasopressin and oxytocin somehow get a stepmotherly treatment whenever it comes to practice. And we were taught that at least 30, 40 years ago that pituitary is the master gland, but now it's like it has the permission of the hypothalamus to say that it's the master gland because someone actually is controlling the pituitary. Just one slide to tell you when you're looking at the etiology. As a KEM student, we have mnemonics for everything. So there were a couple of I's starting from infiltration, irradiation, injury, infiltrative disorders, autoimmune disorders, infectious. And then what is mentioned as genetic disease, for as a student, it was called idiopathic. We really didn't know. So these couple of I's you keep in mind when you're dealing with the hypothalamus or if you're dealing with the pituitary. So one take-home message when you're dealing with hypopituitarism etiology, that more often than not, it's either because of a tumor or because of management of the tumor that they result into hypopituitarism. See, there are other causes which we are discussing today, but they're not at the top of the list. So answering a theory question and handling a case in clinic are two different things. The important thing about hypopituitarism is the age at presentation. A pre-pubertal child going to Nalini would be a different story altogether. Here you're worried about growth, etc. Then it could be progressing into puberty. But our interest today in this audience is adults coming to us with issues. And these issues could be, again, specific hormone dependent, but as you will see in the next 4 slides, these are pretty non-specific and overlapping. So you really have to go more back into the history. I think today morning what we heard on neurology and cardiology was wonderful, telling you that please don't forget your clinical science, don't depend only on investigations. So fatigue, weakness, anorexia, weight loss, today they're very common, but postural hypotension is something you should think about. And if the disease progresses, as in our 2 patients, then it's altered consciousness. So metabolic encephalopathy, for those who really deal with acute medicine cases, you must think about this. Gonadotropin deficiency, surprisingly, is missed till very late. People would say that, oh, it's pre-pubertal, they'll be picked up easily. But if it's post-pubertal, just people don't think about it the way they should be giving importance. So it could be mild changes to something serious, erectile deficiency, infertility and things like that. And women probably a little easier to pick up because menstrual disturbances are something which is given more importance, and something which started and then stopped becomes very specific. So-called delayed puberty is something that you must think of problems more than just psychological and things like that. Nature has made the pituitary gland in such a way that what is really necessary for life, that means cortisol and thyroxine or TSH, they get affected later on, and what is not so important like growth and sexual function gets affected early. So here again, you are not going to get too many patients with TSH deficiency, But one of the pitfalls of investigations today is that we've been taught that rely on TSH for your diagnosis of thyroid disease. You may be correct in about 98, 99% cases, but then occasionally you're going to miss out at secondary hypothyroidism. And today, assays are good, reliable, and whether you do one TSH or you do the whole lot, it's going to cost you the same, the patient the same. So please make it a habit of asking for T3, T4, and TSH. Growth hormone deficiency in adults somehow has not gained the popularity or importance what we should be thinking of. And these are generally previously treated patients, so it's very rare to get an adult with growth hormone deficiency. But they've been treated, operated, and then their Cushing's has been cured or their non-secretory adenoma has been removed. But the patient is not doing well. Something is missing, and then you have to think in terms of growth hormone deficiency. So let's go back to our cases. I need to keep an eye on the clock also. So this lady, if you can think about it, you can save her life, and in less than 24 hours she'll be sitting up. Her sodium was very low, potassium was on the low normal side. You need to collect a blood sample, not to wait for results. It is your clinical diagnosis. Collect a blood sample and start this patient on steroid, hydrocortisone. You may be wrong, nothing serious is going to happen, but if you're right, you would have saved her life. So by the time, in a few hours, you get the report, cortisol was 0.96, the prolactin was 0.57, TSH was normal, 0.97. That may give you some satisfaction. But if you look at the FT3 and FT4, you know that you're dealing with ACTH deficiency, prolactin, cortisol deficiency, the thyroid deficiency, the TSH deficiency. So this is, DHES was also on the lower side. ACTH was low normal. Like I said, that's practically the last hormone to go. But in this scenario, the ACTH was low because anyone under stress, you would expect ACTH and cortisol to be elevated. So with this history that menses did not really resume after her last delivery and that she did not lactate also, you know that you're dealing with Sheehan's. It's not very common today because things have improved. Postpartum hemorrhage is something historical. But there are centers who sort of will tell you that, something very rare to about 3%. 3% is not rare. So you have to think about this diagnosis. The severity of hemorrhage, there is no correlation with symptoms. But the postpartum history is very important. And a very simplistic way of saying is an enlarged pituitary gland because of pregnancy undergoes an ischemic insult because of hypotension and then leads to panhypopituitarism. We're not talking about the autoimmune angle to this, but that's important. In addition, something along the same lines is what is called as empty seller syndrome, and more often than not, it's an incidental finding. These patients are generally symptomatic because of a primary defect or rarely because of a secondary issue. The CSF leaks into the cellar and starts compressing the normal pituitary towards one side. So these patients can remain asymptomatic and normal. Occasionally they develop panhypopituitarism, and very rarely they can have an adenoma in the compressed tissue also. So that also has to be kept in mind. So that gives you an idea how the CSF leaks in and can compress the normal pituitary right to one side. Again, the imaging techniques have evolved over the last 3 decades and they're very wonderful. The second patient also who gave an history of head injury, the answer was that his serum cortisol was 0.4. You don't need a fasting sample and a 8 a.m. sample and a midnight sample. Just when the patient comes, collect the blood sample, start the treatment. The reports may take a few hours. So again, cortisol, the electrolyte disturbances, and you have a diagnosis and you could have saved the patient's life. Thyroid may not be affected in these patients. And yeah, the gonadotropins and the testosterone is on the lower side. Yeah, so this patient fortunately was managed well and went home in good time. So the traumatic head injury, which is not so uncommon, we would have to think about it, and multiple mechanisms which can lead to hormone deficiencies. The third case, which is the polyuria, polydipsia thing, the important thing is the history. Just doing a baseline electrolytes could give you some answer. Cortisol, TSH. So the anterior pituitary hormones are generally normal. The serum osmolality, which is, to put it very simply, sodium plus potassium into 2. You don't need fancy investigations. If you have urinary osmolality, very good. So it's a concentrated blood with a dilute urine, and you know that this patient has a central issue. But I said the common thing in practice actually is psychogenic polydipsia, and the nephrogenic polydipsia is pretty rare, fortunately, because that's something very difficult to treat. I mentioned that these are rarer conditions, but please, it's the mass lesions, the progressively increasing size, and the surgery for these large tumors which commonly lead to hypopituitarism. Certain areas, including Rajkot, as Pankaj tells me, is that snake bites. The venom can lead to pituitary hypopituitarism through multiple defects, and the history that becomes very important. The other conditions that you must think about is lymphocytic hypophysitis, which presents as a tumor, which looks like a tumor on imaging, but is really an autoimmune reaction. So as far as possible. So earlier patients were operated upon by neurosurgeons, but as the endocrinologists became wiser, surgery is generally not required. You see the commonest deficiency is cortisol, and the giveaway thing is not the mass effect, but that thickened stalk. Generally a female patient, postpartum, make a diagnosis, start steroids, and you could save the patient an unnecessary surgery. Pituitary apoplexy, another thing that you should think about, someone presenting with acute onset headache, nausea, vomiting. So it sounds like an increased intracranial hypertension, but the imaging can give you a diagnosis. It could be a neurosurgical emergency, or it could just be a minor hemorrhage managed with conservative treatment. So it's important that neurosurgeon and the endocrinologists are involved when a physician sees such a patient. And treatment, as I mentioned, could be surgery or just steroids. So when it comes to investigations, this is the list that I put here, that the way we go through, Chaitanya told you. So the baseline investigations should be done immediately. The cortisol axis, the gonadotropin axis, the thyroid axis. Growth hormone may come a little later on. Fortunately, dynamic testing now requirements have gone down because our hormonal assays have become so much better, sturdy, reliable. Good old days, it was always a dynamic testing that we relied on. Imaging has, as I said, really improved, and there's hardly a center in India where you would not be able to get a good imaging. And rarely you need to look for additional tests. Visual field, although it's put at the bottom, is a very useful investigation when you're dealing with a pituitary mass. And it tells you, before the MRI also comes, how urgent attention is required for these patients. Hormonal replacement, I mean, that's a term normally most gynecologists would use, but the fact is that when you have pituitary hormone deficiency, you need to correct the deficiency, and as I've already mentioned 3 times, immediate urgent action can save a life. So cortisol axis, you have parenteral, we've been trained using hydrocortisone 100 milligrams 3 to 4 times a day intravenously. If its patient is awake, the oral steroids, whether you're giving hydrocortisone, prednisolone, dexamethasone, are equally good. Start with a higher dose, but within a few days titrate it to the basic minimum requirements, which is about the equivalent of about 7.5 milligrams of prednisolone. Thyroxine, I think most physicians are very well aware. You could start between 50, 75, 100 micrograms. There's no great hurry. You can start with a smaller dose and then build it up. As I said, the hurry is for cortisol. Thyroxine, as a matter of fact, should always follow cortisol after about 2 or 3 days, so that the slow metabolism does not get hastened with thyroxine, and you precipitate a cortisol deficiency. So very often with pan-hypopituitarism, you start the cortisol treatment and then the diabetes insipidus gets precipitated. So patient starts complaining of that. So that's the thing that you need to keep in mind when you're following up these patients. When talking in terms of the gonadal axis, testosterone is the mainstay of therapy for males, and the combination of estrogen with progesterone, or a combination pill or a sequential pill depending on the age of the patient. And the results are very heartening. It's only when fertility becomes a concern that we shift to gonadotropins. Growth hormone is a separate subject altogether, but adult growth hormone is something we must think about, and it would be interesting because you need much smaller doses than what you need in children, and the results are very gratifying. The diabetes insipidus, recently the terminology has changed because there's confusion between insipidus and mellitus. So we like to use the word arginine vasopressin deficiency for central diabetes insipidus, and arginine vasopressin resistance for the nephrogenic diabetes insipidus. And for the central, treatment is straightforward. It's going to be lifelong replacement with vasopressin. You used to get the desmopressin spray, but now we are left with the tablets only. The MEL tablets are 60 micrograms, and they go up to 300 micrograms. The important thing to remember is pan-hypopituitarism or hypopituitarism is a lifelong disease in most cases. Very rarely would they recover. So treating them and saying goodbye is not enough. I remember early in my practice, a senior professor had come to me for the first time. He had been operated at a very good center for a macroadenoma. One of my senior professors was looking after the medical part, and he used to take treatment for a few days, 3-4 weeks, stop treatment, and there were at least 3 episodes of his falling unconscious at the railway station. He was fortunate, and somehow he had not been told that this is going to be a lifelong cortisol replacement, because people still have this thing that cortisol is poison, steroids are bad for health. All that is true, but when you're talking of life-saving situations, the thing changes. So this is my last slide to sort of summarize that hypopituitarism is rare, but it's very important. If you diagnose it, you can save a life. If you miss it, it's very sad for the patient. I have put these 4 axes to tell you that each one needs separate hormone replacement. But the important thing is thyroid treatment, growth hormone treatment can cause a thyroid issue. The gonadotropin issue treatment can cause a growth hormone issue. So sometimes when you're on more than one hormone replacement, you have to keep in mind that a endocrinologist or a person with interest in these hormones is with you to help you in the first few cases. But the last word is, if you made your diagnosis correctly, this patient is going to be as good as any other normal person. Thank you very much for your patience here.
Thank you, sir.